Today, I'm very happy to introduce Dr. Pierre Elias from Columbia. He's an assistant professor in the Division of Cardiology and the Department of Biomedical Informatics at Columbia University Irving Medical Center, where he is also a general cardiologist, and he's also the medical director for artificial intelligence at NewYork-Presbyterian. So the title of his talk today is Developing, Validating, and Deploying an AI Model that Exceeds My Clinical Expertise. And Sean, did you also want to say some words of welcome or?
I just want to say, hey, Pierre, thanks for joining us. We're super excited to have you here. Just to let everyone know, Pierre is taking one of the leadership roles in this Train Cardio Consortium, bringing like-minded groups together. And we're, happy to be a part of that and happy to hopefully expand kind of our role in working together in the future.
Yeah, I'd love nothing more to get to work with this handsome guy who's very well dressed. So it's a pleasure to get to chat with you all today. I really only have one goal with this talk, which is for it to be interesting and to lead to conversation. I'm going to talk through some of this work, but I really, I really want us to have the opportunity to discuss at the end. And it's such an exciting time for the field. No one has it all figured out. We all have lots of struggles. I'm going to be, the first to say there's lots of things we're struggling with and trying to figure out, but it's really fun to get to do that. And so I hope we get to have kind of a nice, engaging conversation at the end and people feel comfortable asking questions. These are my disclosures. We do work with industry quite a bit. So I just want to start with a story. A few years ago, I was staffing the cardiac ICU overnight, and I got a call from an emergency department. And they said, listen, we have this 52-year-old man with no past medical history who's here. He showed up 3 months ago with chest tightness and shortness of breath. And we ruled him out for a heart attack. And we told him, you're definitely not having a heart attack. The one thing is when we listen to your heart with a stethoscope, we hear a murmur. And you should probably go see your primary care doctor about that. But you can go home, nothing concerning, and no heart attack. Life got busy. He didn't get to that primary care appointment. And then he shows back up 3 months later with the same symptoms, chest tightness, shortness of breath. This time, though, he's got much worse and much more labored breathing, and he has to be emergently intubated. They then do an ultrasound of his heart, which shows that he has severe aortic stenosis, which is a type of valvular heart disease. And Columbia happens to be a world-leading center in valvular heart disease. And so they were calling me saying, we want to send him to you emergently. And I said, absolutely, send him right through the middle of the night. He arrived. I spent the rest of the night working on him into the following morning. And unfortunately, he went into multi-organ failure, and he died later that week. If we had just known that he had had severe aortic stenosis, he could have gotten a same-day outpatient procedure and he'd be alive today. And what that fundamentally taught me is you can't treat the patient you don't know about. Modern healthcare still expects the patient to show up and then for us to take care of them. But getting the patient to the right diagnosis, the right treatment, and the right provider at the right time remains an incredibly difficult task. And if we are going to fundamentally change the paradigm of healthcare in order to improve the way that we deliver healthcare, we have to think about methodologies and techniques that can allow us to provide faster, more cost-effective, and more equitable care than what we're doing in this Karen paradigm. So that's where I think artificial intelligence and specifically machine learning and deep learning can make a difference. So I think AI is going to fundamentally change how we order and acquire and review medical imaging over the next 5 years. We're already starting to see this in a very significant way. And our group really aims to be a world-leading center for the development, validation, and deployment of these technologies. And we'll walk through some of those use cases today. So a lot of AI research today looks like this. Let's say you're trying to detect pneumonia from a chest X-ray. What you would do is you'd have a bunch of chest X-ray images that had been labeled by doctors as saying there's pneumonia or no pneumonia, and you train an AI model on it. And maybe the current state-of-the-art model is 70% as accurate as human experts. And then you built a new model, and that new model is 80% as accurate as human experts. So then, you have a paper and you say, hey, we've done better than the current state of the art. And so the human expert interpretation is your gold standard, and your goal is for the new model to get closer to it than the old model. We flip that on its head. We say there's a lot of important clinical questions where physicians are not very good and would not make a very good gold or even silver standard. But you could use a more accurate, more expensive diagnostic test as your label. And then you could say, well, if I use the label of the more expensive, more accurate test, could I teach the AI model to look at the cheaper test and determine whether or not someone has that disease, and thus outperform human experts' ability to interpret that same cheaper test? So this is an example of that. ValveNet is one of the first projects we embarked on here at Columbia. So valvular heart disease is a form of heart disease that affects millions of Americans and millions of people around the world. So you have 4 valves in your heart, and just like the plumbing at your home, they can get leaky or rusty, so they can become stenotic or regurgitant. And when that progresses, it can become life-threatening when it's severe. The problem is you develop symptoms relatively late in the disease process. And if we knew about the disease earlier, we could treat it and we could delay progression of that disease. So we diagnose valvular heart disease with an echocardiogram, or an ultrasound of the heart. So that requires the patient to come in, and a sonographer will do an ultrasound of the heart. It takes about an hour, takes about 30 minutes to be interpreted by a cardiologist, and it's an expensive test, costs between $1,000 and $3,000. So because of that, we're really doing echocardiograms once people have developed symptoms, once they've seen the right doctor. At the same time, we do lots of other cardiac studies that are much cheaper and much more part of routine care. So if you've ever seen any of those squiggly lines on any medical drama or something like that, that's likely electrocardiography, which is measuring the surface electrical activity of the heart. So a 12-lead electrocardiogram is $50, and we do 9 of them for every 1 echocardiogram at NYP. So they're a much more common test than echocardiograms. But myself and Sean, we couldn't look at an electrocardiogram and diagnose someone with valvular heart disease. It's not something we're trained to do, even though we've probably looked at, between 10 and 20,000 ECGs in our careers. And it's not something that, frankly, is thought to be possible. We don't teach it in medical school. We don't teach it in cardiology fellowship. It's not a task that's thought to be possible. But we asked ourselves, if we took patients who had both an ECG and an echocardiogram, and then we told the AI model, this is the electrocardiogram of people with valvular heart disease, and this is the electrocardiogram of patients without valvular heart disease, could we train the model to do this thing that cardiologists cannot do? So the goal here is, can we take these first-line, cheaper, more common tests like EKGs and chest x-rays and perform a form of machine learning-based screening to figure out who needs the more expensive downstream diagnostic test? And that's the ultimate goal. So in order to do this work, the first thing we had to do is have data. And I'm sure everyone here has had to work with data and deals with the same problem. So one, you have to get access to the data, and it's extremely slow and long-standing to try and get access to the data. And then you find out the data is a total mess, or you find out you only have half of it. And then you start talking with clinicians, and you realize a quarter of the time the data is being used in a totally screwy way, and so you should totally discount it. There's all of these challenges. So we had to really organize a cardiovascular data mart, and I think we've created probably the best one in the United States. So we have 8 hospitals and 190 clinical sites that are part of NewYork-Presbyterian, which includes Columbia and Cornell as the flagship academic hospitals, 2 other tertiary care hospitals, and then a number of community hospitals. And so all of the data from all of these sites goes into a centralized data mart. So it's about 12 million electrocardiograms going back to 1985, 1.5 million echocardiograms from 6 echo labs, 8 hospitals, 190 clinics. And that data has all been sanitized, tokenized, validated, and harmonized. So what does that mean? That means we've taken out all of the crazy stuff that happens randomly. We've actually tokenized all of the findings from the echocardiogram. So there's an individual field for ejection fraction, for a degree of aortic stenosis, for tricuspid versus bicuspid leaflets. We've clinically validated it. So we've had people at each one of the sites go through and say, yes, you've correctly interpreted this echocardiogram. And then we've harmonized it. So even though we use different vendor systems for reading echoes at the different echo labs, we've created a single consolidated table where all of the data from all of these different places, community, academic, exist, and we can constantly pull from it. So we can train models on all of the data, or we can say we're going to train the model on 2 sites and then test it on 6 other sites. So, this took 5 years, and now includes, is a live living model. So every time a new electrocardiogram, every time a new echocardiogram, every time a new CAF is done, all of that data goes into this centralized data mart and is readily accessible for all the work that we do. So we were able to publish one of our first papers, which actually looked at moderate to severe valvular heart disease. We looked at left-sided valvular heart disease. And then in a holdout test set of 21,000 patients from 4 hospitals, the model was able to accurately detect valvular heart disease. Again, something we as cardiologists did not think was possible. But this is great. It's a retrospective study. It's big. It was well thought out. But this is still so far from affecting patient care. There are lots of ways AI models can cheat. So we knew what we wanted to do next, which was we wanted to find some way to prospectively test this. So we wanted to run a clinical trial. This is the elevator bank right outside of my office, and this is still how we recruit for clinical trials in 2023. Hey, are you over the age of 18 and in good health? You haven't had an X-ray recently? We'll give you $20 if you come and give us a blood sample. This is not scalable. This doesn't get to the patients who have the highest need. This is not particularly equitable. I practice in Washington Heights. 80% of my patients primarily speak Spanish. So we needed a new way to think about recruitment, particularly for patients who maybe were missed by the health system and needed to be discovered in another way. So we created a real end-to-end pipeline for machine learning, and this has actually become the de facto way that we have done all of our studies, that other people around the health system have done their studies, as well as how we deploy our models now. So regardless of vendor and regardless of modality, as soon as an imaging study is done as part of clinical care, a copy is made, which goes to a research environment. Everything is cloud-based. We happen to just use Microsoft Azure, but I've used GCP, I've used AWS, but the one that the hospital is contracted with is Azure. And we have a full system of storing the data, compute for the data scientists to work on, as well as compute dedicated for running inference. And as soon as the study is done, it goes to the cloud system. We automatically run inference where appropriate, and then we automatically generate outputs. Those outputs then go out to a number of different people depending on the use case. So this was as simple as creating Excel spreadsheets twice a day for clinical trial coordinators. So for all 8 hospitals, every morning I get a risk score for every patient in every ECG, and we know which patients have prior echoes and which don't. And the clinical trial coordinators can automatically look at the list and say, hey, this is a new patient who fits the inclusion and exclusion criteria for the trial, and I'm going to reach out to their clinical team. Hey, this is a patient who meets the criteria. This is a piece of information we need to send back into Epic. Let's go on and do this. And so we've built out this pipeline. It's been running now for a number of years. And we continue to learn a lot. I'm more than happy to share all of the ugly warts and fun things we got to learn along the way. But now this is really, it exists and it gets used at scale. We've probably run, I don't know, maybe 1 million studies through it at this point between EKGs and echoes. And so this is a real-time system that's used constantly at scale across many hospitals and works. So our first trial was the ValveNet AS Discovery trial. So this was a 100-patient pilot trial, adults greater than 60 years who had an electrocardiogram, but no echocardiogram. And they had to be patients who were clinically actionable. So no dementia, no life-limiting disease. And what we did is we ran the model on everyone in the health system and then looked for those patients who were above the age of 60, who had a high-risk electrocardiogram and no prior echocardiogram, who were clinically actionable. So the model looked at all of the ECGs and then it says, hey, I think that person has valve disease or structural heart disease. and they don't have a prior echo. And so those would be the patients we would reach out to. And so our primary endpoint was moderate to severe mitral regurgitation, aortic stenosis, or aortic regurgitation, which is what the AI model was trained on. But very early on, we learned something, which was the signal to noise ratio was not perfect. The model can't say for sure that person has severe aortic stenosis, but the model, we were realizing like pretty early on, was it's good at saying something is wrong with that person's heart. Something serious is wrong with their heart. So our secondary endpoint was structural heart disease at large, which is all of these things here. Basically, these are all the things where, if I told Sean one of these things was true about the patient and that they didn't have an echo, we would immediately agree the next step is get an echo on them. It's like, that's a clinically actionable, important thing that should be confirmed because we're going to have a very obvious next step. And so the outcome is really important, right? This model isn't giving you a risk score of like their 5-year mortality, and then you're kind of like, well, what do I do with that? It's of the people who have an ECG and don't have an echo, do they have something that would warrant getting an echo? And then everyone kind of agrees what the next step is. Go get an echo on the patient. And so the model was not trained on structural heart disease as a label. It was only trained on the primary endpoint, but we wanted to see how well would it do at picking up the secondary endpoint. So you're some of the first people in the world who are getting to see this. Please, be cognizant of that. This is the pilot clinical trial, as well as we let the model run in the background for a year. And what we did is we ran it on everyone who had an ECG and no prior echo, and then we followed those patients. And a certain proportion of those patients would go on to get an echo as part of routine clinical care. So amongst those patients who went on to get an echo as part of routine clinical care, how did the model perform? So for the pilot clinical trial, the 100 patients that we recruited, those with a high-risk score had a 17% positive predictive value for left-sided valvular heart disease and a 57% positive predictive value for structural heart disease. And then for those ones that we recruited at moderate risk, none had left-sided valvular heart disease, and 20% had any structural heart disease. And then in our prospective study, we saw very similar stratification. So amongst those patients who would go on to get an echo, the high-risk ones, 29% would have newly diagnosed left-sided valvular heart disease, 72% with any structural heart disease. The moderate risk, 10% and 43%, and 3.3% and 22%. Again, basically all of these are things that we don't believe as cardiologists were diagnosable from an EKG. The one exception would be LV wall thickness, or LVH, and pericardial effusion. But other than those, these are all things not thought to be interpretable from an EKG, and yet we were seeing the model had very high positive predictive value when recruiting patients and when just being run in the background on 8 hospitals. So what this led us to do is say, there's a really foundational question that we want to answer here. This was great, but the positive predictive value of 17%, we knew it was going to be low, and this is what we really lost sleep over. So I trained a model on people who have both ECGs and echoes, but then I want to use it as a screening test in just people who have an ECG. People who have both an ECG and an echo, that's a sicker population, right? They have more care, they're generally going to be sicker, and the prevalence of the label is going to be higher, right? So the thing I lost sleep over for 2 years as we were running this study was my model was no longer going to be calibrated. 0.7 was no longer going to mean 70% as a positive predictive value. So how do we know how well this model is actually going to perform in the real world in our screening population? And what we knew for sure was the positive predictive value was going to go down. So what did we do? We modeled all of the different possibilities of what the underlying prevalence was, and we asked ourselves, what would be a high enough positive predictive value where it would be good? And when we talked with a bunch of experts, we said, hey, if 1 in 5 people, if the positive predictive value was 20%, would you send 5 people for an echo to find 1 new undiagnosed case of moderate to severe valvular heart disease? And people said, absolutely. So we felt comfortable proceeding with the trial under that premise. But what we realized is, well, the real question you want to ask is, of all the people with an ECG and no echo, who needs an echo? You could ask that larger question, and that is a label that's more prevalent, and thus you would have an even higher positive predictive value. And so that's what we wanted to do, is we wanted to ask this broader question and build a model that we think fit within clinical care and would also be more impactful. So we created a second generation model that was trained on all of those pathologies. And then we looked at all of the 8 hospitals at NYP. And what we saw was very similar performance across all of the hospitals. And this was true whether or not the hospital was included in the training data. Very similar performance, whether the EKG was done in the clinic, in the emergency room, or inpatient, which is very interesting because the label prevalences are very different. So you're way more likely to, if you had an inpatient EKG, you're way more likely to have structural heart disease than an outpatient ECG. But regardless of that, the positive predictive value, the precision, and the AUROC was almost identical. And then same thing for patient demographics, very similar performance across race and ethnicity. So again, please be cognizant of this. This is under review at Nature currently, but I just like to share results because I think let's talk about the most cutting edge stuff. We trained this model, and then we were able to validate it at 3 other health systems, Montreal Heart Institute, Cedars-Sinai, and UCSF. We saw very similar performance across the band, got probably like a 4% drop in performance at the external test sites. And then we did something really fun and interesting. We had 13 cardiologists look at 150 EKGs, and they would see the EKG twice, once without the EchoNext score and once with the EchoNext score. And we explained to them exactly what EchoNext was, what the performance was, and these are like the cardiologists who I send my family members to. Like, these are the best of the best. We asked them, does this patient have structural heart disease or not after looking at the EKG? And what we saw is, and this is like about 3,200 interpretations. So the cardiologist's accuracy was 64%. And then when the cardiologist was given the EchoNext score, it went from 64 to 68%. And then the AI model alone was 78%. So the cardiologist alone was as far away from random chance as they were from the AI score. And then we talked with all of these cardiologists, and the email chain was wild, I'll tell you that much, after we showed everyone the results. And it wasn't that cardiologists were surprised how bad they were at this. And myself and Tim, my co-director, we took the survey too, and we recused ourselves from the results, and we were no better. I've spent the last 5 years like building these models. I know like everything there is about it, and I was no better. My baseline accuracy wasn't better, and my utilization of the model wasn't better, because my cardiologist instincts just kicked in, and I was like, oh, this patient definitely does or definitely doesn't. And whenever I disagreed with the model ended up being right. So there was, I think, a couple of interesting things. It's not that we were amazed how bad we were. We just didn't think this task was possible. The thing that was kind of amazing was the AI model is able to do it. And there is that information that exists on these EKGs. And clearly, there needs to be some sort of calibration that happens. We just don't know how to interpret these findings. So we just don't know how to trust them. The last part is we had the model running in the background for 9 months for patients with new ECGs, no prior echoes. So these patients weren't in our training data. They weren't in our test set. They were totally new patients. 9% of them were predicted as high risk. And half of those patients would go on to get an echo as part of routine clinical care in the following 9 months. But then half of them wouldn't. And then amongst the half that did go on to get an echo, the positive predictive value was 74%. So the model was really quite good at predicting, hey, that you're about, this patient is very likely to have structural heart disease. So what's interesting is I feel like this is smoking gun evidence that there's a lot of people out there with undiagnosed structural heart disease. And so this was what led us to have the confidence to do what we're doing now. Going back to this kind of inference system, we took that data and then we have a dashboard that runs constantly. And so this looked at, high-risk patients, high-risk EKGs, how many get echoes, how many have cardiology encounters. And what we were seeing is a lot of these patients with high-risk EKGs who don't go on to get an echo, they show up in our emergency departments, whether it's Columbia or Queens or Cornell. And you can see what they were diagnosed. The ones who do go on to get an echo, what they get diagnosed with, a lot of it is heart failure. Some of it is severe LVH, pulmonary hypertension. But these are very serious things. This is something like 2,000 people who go on to get diagnosed with like new diagnosis of heart failure. So this led us to say, we really want to engage with the emergency department and see if we could do something. So we're really excited. This is a trial that's starting in about 2 to 3 months. So what happens is every patient who shows up in the emergency department who gets an ECG, that ECG is going to be automatically run through Echo Next. If they do not have a prior echocardiogram and they have a high-risk EKG, an alert will fire saying, hey, we think this patient has undiagnosed structural heart disease. We recommend getting either an inpatient or an outpatient echo. Now, Sean, not to put you on the spot, but how often do you read BPAs?
Not often.
Yeah, for me, it's between 0 and 0%. I like literally like press escape before I've even read it. It's like they're just like an annoyance, a hindrance, and things like that. So we know this is the case, right? We were trying to meet people where they are. So the alert will fire, but if the clinician, and if the alert fires and they agree, great. If they disagree with it, they think it's not clinically integrated, great. We're not going to get it, right? The patient has an outside echo, or the patient is on hospice care, or they have dementia, great. We're not going to do anything. But if they ignore the alert, our community teleparamedicine program is then going to evaluate that patient. And then if the patient does not have a contraindication, we're going to order an echo on that patient. So we're basically treating this AI result like an abnormal troponin level. We're saying like this is the equivalent of like a laboratory result that must be acted upon. And if the clinician who's taking care of the patient isn't going to act on it, our centralized system is going to act upon it. And what we're going to look at is over a 90-day, like over a 20-month period, half the time the model will be on, half the time it'll be off. Does it change the rate of new structural heart disease diagnosis at 90 days? So basically, compared to like standard of care, if you do this and you say, when this result is high, that is someone who needs to go get an echo. Does that change the rate of new structural heart disease diagnosis in 90 days? So we're really excited because it tests a lot of things. It tests one, what happens, like how often will clinicians take this alert seriously, right? We all want to do clinical decision support, but how often are they going to actually take this seriously? Two, is it appropriate to have an AI safety net? Is a AI risk score plus a nurse manager enough to say that's someone who should get an echo? And three, who are these patients? So one of the things we're seeing is there's very obvious differences in referral patterns for Medicare, Medicaid patients, patients who speak another language, patients who are more likely to AMA, or have difficulty getting engaged in care, things like that. I mean, if any of you have gone to the ED and they say, hey, get a doc, you don't need to be here, but just get a doctor's appointment for next week, try and call a doctor and get an appointment. It's impossible, right? Almost every time I need an appointment or something like that, I have to call in a favor, or I need to show up at the clinic itself because I work at a hospital. It's really hard for people who are, in disadvantaged situations to get access to clinical care. And so does this help us triage the people who need help and aren't getting it? That's what I really want to answer. And this is actually this is so outdated. We literally the four of us who are PIs, we were literally like yelling at each other earlier today about like what the BPA needs to be. But we're gonna have a BPA. It's gonna give people information and things like that. But it's changed so much, so this is already out of date. Changing tracks a little bit here. Cardiac amyloidosis is a relatively rare form of heart failure. It's very near and dear to our hearts here at Columbia. We're a world-leading center. Matt Maurer, who's one of my mentors, helped invent the pyrophosphate scan, which is a non-invasive way of diagnosing this disease. He wrote the first New England Journal paper on tafamidis, which was a medication shown to have a mortality benefit for these patients. So we asked ourselves, can we diagnose this disease from EKG and echo? And so we built a model, and many people at this point have built models like this. Rahul Deo, who was at the Brigham and OBI for a long time, him and Shinichi Goto, they have a model. The Mayo Clinic has a model. David Oyang has a model. Many of us have built these models and kind of replicated these results. So, this is a disease that requires very advanced diagnostic testing to diagnose. But using just EKG and echo, it looks like you can indeed find these patients. But then Matt said something very interesting to me. He's like, listen, I know this disease has a preponderance in Black and Caribbean Hispanic patients, but my clinic is all white people from Jersey and upstate New York. What's going on? I was like, that's very interesting. Let me look into that for you. So this is the relative proportion of white, Black, and Hispanic patients who just show up at our doorstep. So it's about 46% white, 17% Black, 38% Hispanic. And then if you look at who gets ECGs, very similar. Echo, more expensive test, starts to get a little more white. And then the pyrophosphate scan is 80% white. So the people we send for advanced diagnostic testing for cardiac amyloidosis are twice as white as the general population we care for. So everyone talks about how AI has the risk of being biased, and it absolutely does. But clinical care today is biased. So I think AI could actually potentially help with bias. So what we did is we took an at-risk population, people who kind of fit into a diagnostic gray zone, who had like increased wall thickness and the like, and then we ran our AI model on that population. And then it said a certain group of those people were positive. And then we looked at, well, what was the relative racial breakdown of those people that it called positive in comparison to our current PYP referrals? And lo and behold, our AI model would refer people who were 54% white, 16% Black, and 31% Hispanic. So a really significant change. So we think that there are ways that AI can profoundly change referral patterns and potentially help deal with the bias that exists today. And so we're running a pilot trial of this right now where we're recruiting patients, and we're committed to at least half the patients being Black or Hispanic in the trial to try and correct for this issue. Another one of our projects looked at chest x-rays. So chest x-rays are the most common diagnostic image of the heart in the world, but they almost never provide meaningful information. They tell us a lot about the lungs, but radiologists who read chest x-rays, they have just kind of one pathology they call in the heart, cardiomegaly. And it's a useless diagnosis. It does not lead to a very clear next clinical decision step. At the same time, most patients only get diagnosed with heart failure when they become symptomatic, which is called stage C heart failure. But before there are symptoms, the heart structurally changes. It thickens and it dilates, which is stage B heart failure. So we asked ourselves, instead of trying to detect cardiomegaly, could we detect these changes from a test as cheap and prevalent as chest x-ray? And if so, you could take this very common test and repurpose it as a screening test for one of the most common causes of death in the world. So this paper is actually coming out in 1 to 2 weeks in the European Heart Journal. And then I don't know if anyone here is MIT affiliated or works with PhysioNet. We're very excited to share that the entire data set and the model will be on PhysioNet at the date of release of the paper. But this model detected severe left ventricular hypertrophy and a dilated left ventricle from chest x-ray. We validated it at Stanford, and then we had to go head-to-head against 15 radiologists, and the model outperformed all 15 radiologists in detecting true cardiac pathology. And so this is the first AI model to exceed radiologist performance in cardiac pathology. So we're really excited for this paper to come out and to share these results. So we've talked a lot about AI helping with things that are not currently possible by a clinician expert. But can it help with the dumb stuff too? I imagine many of you are feeling this too, but the labor shortage in healthcare is so significant. It's really hard to hire people. The labor shortage is only getting worse. And there's things that are very, very time consuming. So this is an echocardiogram, an ultrasound of the heart. And we're looking across the mitral valve. And I have to go and look and find the specific wave that has the highest peak velocity and a good envelope. And then I have to drag my mouse and trace out this thing. And if any of you have like signed your signature using a mouse, you can see it's like pretty clunky, it's not perfect and things like that. So this is very time consuming and my time is quite expensive, which makes the test very expensive. So there's a number of things like this where we think AI can make a really big difference. So we have built out a full suite of tools to improve both the speed and accuracy of echo interpretation. So here's a perfect example. So this is an image where we're looking across the aortic valve and we have to measure the velocity time integral of the wave. And this is the cardiologist doing it. And usually what they'll do is they just do one wave because it takes time to do. But if a patient has an abnormal heart rhythm like atrial fibrillation, you're actually supposed to do a number of waves and get the average of them because the loading conditions of the heart vary from beat to beat. But no one has time to do that. But an AI model is more than happy to do that. So here it can not only accurately segment out the wave, but it's more than happy to do all of them. And so our model can automatically determine, hey, you're looking across the aortic valve, and I can automatically get you the velocity time integral, the peak velocity, so on and so forth. One of the other most common tasks, or most important tasks from an echocardiogram is calculating the ejection fraction. And this is done a number of different ways. So one way is to segment out the heart, where you actually draw how big the heart is at end systole or end diastole. Again, tracing this out takes a lot of time. And so we just do it for 2 frames of a 120 frame clip. But our AI model is able to segment out the heart for all 120 frames. A number of times, though, the model will not be good enough the image will not be good enough to do segmentation and get an accurate ejection fraction. And so then you do a visual estimation. And we've also built out visual estimations. And we've shown basically state-of-the-art accuracy and equivalence to like physician interpretation for both segmentation and for visual estimation and ejection fraction. So here we can just automatically get every single frame and segment it out where appropriate, or we can just do visual estimation. Lastly, one of the tasks that's kind of been considered the peak of the mountain for deep learning is regurgitation. So, I talked about those 4 valves in the heart and how they can become leaky or they can become rusty. The leakiness of the valve is one of the most arbitrary and difficult things for us to interpret on echocardiograms. It is simply an extremely arbitrary thing that requires volumetric analysis of something that is like a moving, beating object. Echocardiogram is probably the single most difficult modality for interpretation in all of medical imaging. And I'm sure there are some other ones that are as hard to interpret, but it's truly up there in that the image is not crisp. It's extremely variable from patient to patient. The quality of the images is highly variable, and the heart is beating and moving at the same time. All of those things mean like you get very, very heterogeneous data compared to like a CT scan where there may be very complex pathology on a CT scan, but the quality of the imaging is just much more superior compared to an echocardiogram. So regurgitation, it was really kind of the top of the mountain. And there haven't been really any papers showing high quality interpretation of regurgitation. So we built a model, and we were very happy to see that the model did quite well in detecting mitral regurgitation. And then, there were times where the model disagreed with the human expert read. So for example, the model may have said severe, and the human expert may have said moderate. So basically there was a 2-step difference. So, moderate to severe versus severe, moderate to versus severe. So we looked at all of the cases where there was a 2-step difference, like moderate versus severe or mild to moderate versus moderate to severe. And we had 3 echo attendings blindly interpret those echoes and adjudicate. So they didn't know what the read was. They didn't know what the AI model said. We just said, hey, interpret this echo. And it was very interesting. So about half the time, if the model said severe and the human said moderate, the adjudication group would say moderate to severe. So they'd say the answer is in the middle. A quarter of time, they would say the human expert was right. And really, that was cases where the model was just screwing up on things where the model should have just known to turn itself off. So the patient either had a giant right ventricle, or they had an impella in. They had a critical care device in their left ventricle. These like very atypical cases, the model would fail. And then a quarter of the times, the experts, the adjudication committee would agree with the AI model. And so these AI models are already getting to a point where a quarter of the time where there's disagreement, they're right. And the expert's interpretation that was put into the medical chart was wrong. So we're really excited to see what happens as you kind of develop this further, test this more, and the like. Lastly, I just want to talk a little bit about this network that we've created. So Train Cardio, which Sean was talking about, is the Task Force for Research Advancement in AI and Cardiology. This is very lonely work at times. It's really hard to get some of this work done, right? It's very data intensive, and anyone here who does data science knows, yeah, it's like great and exciting to talk about the AI work, but like that's like 10% of the work, right? Like getting access to the data, cleaning that data, making sure you have a good question that's like clinically meaningful, but also answerable with the data that you have. That's a huge part of it. And now we're also on the other side of that, which is getting it implemented and then testing it in the real world and showing an impact. That's another part of it. So, I used to think like the AI part was the hard part, and now it's become like one of the easiest and smallest parts of the whole thing. And so that work can be really lonely, and it's very, there's a lot of shared learnings. So this group is meant to be a group of AI researchers in the cardiovascular space. We meet, every quarter. We're now going to try and meet up also at the conferences to share best practices, to make it easy to validate one another's work. And we've really come a long way. A few years ago, it was really hard for us to validate one of each other's models. But now, David Oyang on the echo side and myself on the EKG side, we have really shared. We have GitHub libraries that have like how to do deep learning from soup to nuts for like EKG and echo. So like, how do you pull the data out of Muse, the system? I have a full tutorial on that, plus like an example EKG. How do you then like build deep learning models specific to electrocardiographic waveforms? How do you interpret those results? All of that, we've made freely available, and David's done similar things, and we're, also soon going to hopefully make data available. So we want to try and get people on like a similar standard, so validation work is easier. And we also want to hear about exciting projects that other people are leading, so that we could be validation sites for those projects. We can be collaborators on those sites. We could be on each other's grants and things like that. So, we're really lucky to have Sean as the representative in trained cardio, and it's allowed us to do more interesting work. An example is, this is one project that came out of that. So utilizing EKG to adjust 10-year cardiovascular disease risk. So this is like one of the foundational questions in cardiology. It's like, will a statin save you from a heart attack, right? So, should you be on a statin? This is something where there's a very well-validated model that is used to answer this question, but it uses things like, do you have high blood pressure? Do you smoke? And EKG is something that would absolutely make sense to include in this risk score, but there's no easy way to include, a waveform into what is otherwise like a numeric score. But this is a perfect machine learning problem. It's dimensionality reduction, right? So it's a perfect machine learning problem. So we built these machine learning models to assess 5 and 10-year cardiovascular mortality. And it was tested on over 1 million electrocardiograms, multiple vendor systems from Stanford, Cedars-Sinai, and Columbia. And we saw it works across sites, it works across vendors. And this was a really cool result. This just came out. Weston Hughes at Stanford led this work, and I think this came out in Nature Digital Medicine. So if you look at the pooled cohorts equation, which is the way that we currently put people, so you can see there are people who are low risk, so no statin, and then the moderate and high risk where you put people on a statin. But then if you took this low risk group and then you looked at them and you said they're high risk by SEER, the EKG interpretation model, that group who are high risk by SEER but low risk by pooled cohorts, their 10-year cardiovascular disease risk was actually above 7.5%. So that is a group who should be on a statin but currently aren't. And then the same thing is true here. If you take the moderate risk people who have but low risk by SEERs, their risk is under 7.5%, so they should not be on a statin but currently are. And we haven't done this ourselves, but the Mayo Clinic has validated one of their AI waveform models at the wrist with an Apple Watch. So you can imagine, one, you could do this with a 12-lead ECG, but two, you could also just say, hey, you're trying to figure out if you should be on a statin or not. You're right at the borderline, right? Like, let's say you take the patients who are between like 6 and 9%, something like that, right? Where you could imagine there's like, it's a gray zone and there's some wiggle room. And you say, well, you're between 6 and 9%. Why don't we do an EKG, or why don't we do an Apple Watch tracing? And like right now you're 6.5%. And then that Apple Watch tracing may push you from 6.5 up to 8%. And then we say, yeah, I think you should be on a statin. Or, you're right at the cusp and you don't want to take a pill. I feel more comfortable. Let's do this and see if it pushes down or pushes up your risk, right? And so you could see this way of, this is something that affects 30 million Americans, is an important decision. There's an obvious way to use EKGs to help do this. And so these are the sorts of things where we think machine learning and deep learning can really make a meaningful difference and be applied and be applicable and have impact. The last thing I'll say is, we have this fantastic two-part, 10,000 word review of all things cardiovascular AI coming out in JACC. Probably it'll come out in the next 3 months or something like that. We just sent in the revisions. But we want that to be a comprehensive review of a bunch of different modalities, all of the key studies that have happened. And then part 2 goes into generative AI. What's the regulatory landscape look like right now? Where are things headed? Like, why are these things, not getting used yet in the clinic and things like that? And so, we hope for that to be, it'll be a 2-part review of the week in JACC, probably coming out sometime in a couple of months. So, if you're excited by this work and like you want to learn more about it, I'll point you to that as a place where you can kind of get a lay of the land and hear about all the exciting work that many people are doing.
Great. Thank you so much. That was a fantastic talk. I would love to open it up to questions. You can just unmute yourself.
Thank you so much. This was such a wonderful, wonderful, beautiful talk. I was wondering if you could explain more about your screening setup, the AI-based screening setup that you did at these 8 different hospitals, and what the challenges were. Because as ML4H, we love to go in that direction, and I don't know if it fits in this session, but we would love to hear more about your experience and learn.
Could I ask, like, my guess is you're probably asking the question because maybe there's like a specific problem you're facing and things like that. So when you're talking, like, are you talking more about like the translation of the model from people who have ECGs and echoes to just ECGs, or more, hey, how did you get this like turned on, or was there a lot of pushback from people about having this running in the background? So my guess is you probably have
the latter, the one that like the setup that you put in place in the clinic, so that whenever somebody does an ECG or echo, you run the models in the background. That setup.
Yeah. It's a great question. It took a lot of time and a lot of building of political will and support. So I started doing this work 5-ish, 6 years ago, and like at that time, I couldn't even get access to the data. Like I couldn't get anyone senior to me to pick up the phone and tell cardiology IT or IT to give me access to the data. And like literally for 6 months, I would email the IT, like the cardiology IT supervisor person every 3 weeks, and they just wouldn't respond to my email. Every 3 weeks for 6 months, I would just email them and like just wouldn't get a response. And everything was just kind of falling on deaf ears and all of that sort of stuff. It took a while, and it took a number of things, right? So one, you have to have political support. Like leadership has to see this as something that's important.
Mm-hmm.
2, you have to show competency, and competency means like you understand the technology, you understand data structures, the databases and things like that. And you also understand like other people's jobs and like what brings them stress. So like I brought down the Muse EKG system probably like 12 to 15 times, right? I created a lot of stress for other people because we didn't have a good way to get all of the prior EKGs. So we like, if you guys have Muse, and you guys have now figured this out, I think, at least for MGB, I think this is figured out, but there's no way to pull all of the retrospective XML EKGs and get their raw waveforms. You would have to manually print them. And so I remember talking with Rahul about it and talking with other people about it. We all had to set up bots. So for like 4 months, I had to like set up a bot that I would reset every day to like manually click and print all of the old EKGs and stuff like that. Because otherwise we'd have to go to GE and they would charge us $100,000 to pull out that data. But as soon as you can turn something on and it does it for everything prospectively, right? Mm-hmm. So one part is you have to like, you talk with people, you understand the system. You have to have the political will where people understand that this is appropriate, this is where the health system wants to go, and things like that. There is a lot of fiefdoms that exist, right? There's a lot of people who say, this is my data and things like that. And so you have to navigate those sorts of things. And those were challenging. But I think you create partnerships, you understand what motivates people, and then people get comfortable with this idea of, yeah, this is the right thing to do. And then also people have to understand, like, is this really their data, right? You can't say the patient was, this is this is data from the emergency department, so it's ED's data or something like that, right? That's not necessarily how it works. So you have to understand, like, who controls the data, who makes the ultimate decision, are you aligned with people, and then how do you build relationships? So like we would never like kind of like just step over the emergency department and say like, no, we're going to do this and things like that. What did we do? We just submitted an R01. We built relationships with 2 phenomenal research investigators in the ED, and our project is much better for it, right? And we show the emergency department that we're supporting them, they're getting funding, and like we can grow the pie by being part of this. So it's a never-ending balancing act, but it starts with where's the centralized data service, who ultimately kind of makes this call, and then just navigating it. But yes, there is a lot of politics to make this happen. It's why I have an NYP title. It's why I have a Columbia title. It's why we spend a lot of time on this for sure.
Thank you. Right.
Really great talk. Is part of the first part of your talk the ECG-based model for detecting aortic stenosis and other disorders? You kind of focused on positive predictive value, which makes sense in terms of building trust in the model and reducing cost of doing unnecessary echocardiograms for patients and so forth. I was wondering, maybe this is more of a policy question, but I would think that like recall is also quite important. So say there's an ideal future where everyone really trusts this model and only ever orders echoes for patients where the model specifies a score above a certain threshold. If the recall is not perfect, then there's a sort of non-trivial number of patients who might not get an echo, but could also benefit from having a study done. I guess curious your thoughts around that.
Yeah, it's a great question. It's something we spend a ton of time thinking about. So for anyone who's like MD or clinician in the room, recall equals sensitivity and precision equals positive predictive value. As someone who lives in both worlds, I've come to realize the terminology is different. The terminology is different when for these things. So it's a great question. So, when we first ran this trial, right, like I was losing sleep for a couple of years, right? I had no idea if this model was going to work in the real world, right? So one, it's easy to say it's going to work in a retrospective data set, but will it work in a prospective data set? And then 2, this transportability problem, right? Or this I guess it's not a transportability problem, but more a population shift problem, right? So really massive population shift, models no longer going to be calibrated. So we really erred on positive predictive value, and there's for a couple of reasons. So one, we increased the threshold from 0.5 to 0.6. And 2, we were really talking about deep learning version 1.0 and building trust, right? So right now, everyone is delivering the standard of care that they think is appropriate, right? And so there are clearly going to be some percentage of patients that are being missed, but everyone is delivering a standard of care that's appropriate. So you have to start from a premise of, if you're going to alter the standard of care, you better be pretty darn right? So it's like when you deliver a result, you really want to build trust with the clinician by saying, if I am bothering you about this, the positive predictive value is high, right? We spent a lot of time modeling different prevalences and what would the precision recall curves look like on that and all of this sort of stuff to really kind of try and hone in on this. And it ended up being we predicted a precision, a positive predictive value of around 20%, and that's what we saw. But so in deep learning version 1.0, with that kind of premise in mind, I think you really need to build trust with the clinicians. Over time, you do want to build something that's cost effective, right? And right now, the model's positive predictive value of 72% for structural heart disease, that's twice as high as general referral for echo. So if someone just gets referred for an echo, about 1 in 3 of those patients is going to be positive for structural heart disease, right? So it's it's the positive predictive value is much higher than just the general routine clinical care echo and things like that. The thing we haven't looked at, and we're very purposeful about this, is what if someone wants to order an echo and then you say, hey, you don't need to order an echo on this patient, right? What's the negative predictive value and stuff like that? And that's very purposeful. We think these technologies are still very new and there's a lot we have to learn. And we never want to stop a clinician from ordering a test that they want to order from a patient. Sean and I, we just had the Train Cardio meeting, and we were talking to some other people. As soon as you do that, this will be weaponized, right? Some insurance company will use this and say, well, the Echo Next score was low, so now you need a prior auth to get that echo, right? And so I am desperately afraid of this being weaponized in that way. So we're very conscientious of that. And so we say, we have a very clear focus here, which is don't get in the clinician's way, but find low-hanging fruit where you can feel confident that you're providing a piece of information that is going to change clinical care and has a relatively high degree of accuracy. And then over time, you can start to say, okay, do I want to drop the threshold a little more? Will I tolerate sensitivity? You can start to do proper cost-effective analysis and say, hey, this model is cost-effective all the way down to a threshold of 0.4 or something like that. So it's a great question. It's something we've thought a lot about, and we've been strategic in why we've made those decisions, and definitely hard-won decisions for how we're running these trials right now.
Great. I think that's time. Thank you again for the fantastic talk. I'm going to put in again the link to the mailing list. We had 14 people sign up in the last hour, so that's great. Our next speaker will be on April 3rd, Dr. Emily Altsenser, whose research is on machine learning and specifically natural language processing for healthcare. So we will hopefully see you all in a month. Thank you very much. Bye.